Sure.
Yeah.
Cheers for the pledge.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
They move the flags over there, huh?
All right. Welcome to the April 10th, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for further viewing. Shelley, please vote.
Director Eapen,
Present.
Director Wallace, Director Nicholson,
Present.
Director Yee, present, and Director Stewart.
Present. Move on to oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? No?
There are none.
Sorry, any written communications? Shelley?
There are none.
And we'll move on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No. Does any member of the public want to remove an agenda item from the consent calendar? No. So may I have a motion to approve the consent calendar items A? Director Nicholson. Yeah.
Mr. President, I move that the Board of Directors approve the consent calendar item A.
I'll second that. And then Director Eapen,
Aye.
Director Wallace,
Aye.
Director Yee, aye, and Director Stewart.
Aye.
So then we'll move on to the presentations.
All right. It is my pleasure to introduce Laura Anning, our Patient Experience Officer. Laura has been our Patient Experience Officer at Washington Hospital Healthcare System since January of 2023. She obtained her sports medicine exercise physiologist degree at Eastern Michigan University and has been a leader in healthcare and wellness for over 30 years. She comes to Washington after 10 years at Banner Health with leadership roles in patient experience, physician experience and development, and most recently in nursing experience and development. Laura is a former talent development director, account executive, and is currently pursuing her executive coaching certification. So she is here to join us. I know her voice has been a little bit raspy, and if she's got any challenges, I know Terry's gonna kind of help out. So thank you, Laura, for being here.
Thank you. I'm going to go ahead and share my screen. And I have throat lozenges and inhaler water. I think I'm about as prepared as I could possibly be.
I got your back.
So can you
Sounds like a good patient experience.
Excuse me. Thank you. All right. So can you all see my screen okay?
Yes.
Yes. Yep.
All right. Well, it's nice to see all of you again. And thank you so much for including patient experience on the agenda tonight. And I often like to end my presentations with a quote, but this time I decided to start with one. And it's by Lyndon Johnson. And the quote is, "If you're not listening, you're not learning." And listening is really going to be the theme you're going to hear throughout the presentation tonight. At Washington, we really strive to listen and learn from our patients and families, and we want to really know what we're doing well, but most importantly, we really want to understand what we can do better. And understanding these two things, and then most importantly, taking action, is going to help us improve the patient experience. So as an organization, we're going to focus on asking the right questions, listening to what our patients, our families, and our employees need, and then responding with the right actions. So let's review how we're currently gathering information and feedback from our patients. And later on, I'm really excited to share how we now have the ability to gather significantly more data, feedback, and insights. So I know this slide explaining the patient experience survey process isn't new for you, but I thought it was worth revisiting. So every day, all of you know that we have many patients receive care here. It could be in the ED, it could be in a clinic, it could be an inpatient stay. And then afterwards, randomly selected patients are sent a survey or an e-survey or paper survey or e-survey asking them to answer questions about their experience. Press Ganey then gathers that feedback and we receive our scores and comments monthly. In addition to our scores and our comments, we also receive our percentile rank. And this is important because it shows how we compare to other healthcare organizations in their database. And the general categories for the question are listed on this slide, and they do vary a bit by service line. There is, however, a question on all of the surveys that asks, how likely are you to recommend Washington to your friends and family? And because this is what we call a top box methodology, what that means is that only the best answer matters or counts. And that answer is definitely yes. It has to be selected if it's going to count. And research shows that patients' likelihood to recommend us to friends and family is the best indicator of their loyalty and their desire to continue to choose us. And we definitely, obviously, want to maximize the information we receive from Press Ganey. And we've made some, I think, really significant process or improvements in the past year. For example, we wanted to better understand the needs of some of our specialized populations. So we added a pediatric survey, a special care nursery survey, and also a specialized oncology survey. And I'm really excited about this one. We are also partnering with Press Ganey to begin sending paper surveys in our patients' preferred language. So the languages we're going to start including are going to be Chinese, Punjabi, Spanish, Tagalog, Farsi, Hindi, Vietnamese, and Telugu. And our hope is that with this that this will help increase our N sizes and then also teach us how we can adapt our experience to meet our patients' unique cultural needs. And then we're also collaborating with our admitting team to decrease the number of non-deliverable surveys. And this is really accomplished by making sure that we collect accurate home addresses, email addresses, and then mobile phone numbers. And while we're on the topic of patient surveys, I have been asked a few times, well, not maybe a few, a lot of times, about how and if COVID impacted patient experience scores. So the information on this slide was provided to me by Press Ganey, who again has the largest database of patient experience scores. And this is a trend line showing how scores nationally were impacted by COVID. And you see when COVID started in March 2019, there was this initial increase in inpatient likelihood to recommend scores. And you see where I have that little red star. And then the scores they started to go up and down for a bit. And this is really at the time, and I think you probably remember this, when people were rallying around healthcare workers and they were voicing their appreciation. They were banging pans. They recognizes the sacrifices they were having. And then starting around April 2021, you can see the scores started this really rapid decline. And what I found interesting is that the data indicates that the area impacting the decline was around the question about cleanliness. And it's believed that patients and families, they started to really notice and inspect everything that was going on in the room and really started also watching hand washing. And I can remember around this time too, that's when patients were, starting to get angry. Burnout was starting to set in, travelers were needed, visitation was limited. There were just a whole host of challenges. And then starting in about May of 2023, the scores nationally started to increase. So when I saw this trend line, it sparked my curiosity, and I wanted to see if our scores followed the same pattern. So here's a graph that shows how Washington compares with the national average for likelihood to recommend in the hospital. And the national average is still the pink line, and our score is the blue line. And then the black line is our fiscal year 24 score goal. And you can see that the trend is broken down quarterly versus monthly, like on the other slide. And what jumped out at me first was that our scores are higher than the national average. We also experienced a decline in March, but the trend didn't continue as long. And then our improvement started a little earlier. And the good news is you can see that it continues to improve. And this slide shows our ED likelihood to recommend trend. And similar to inpatient, the emergency department also experienced a decline after COVID and continues to rebound. And this slide also highlights Washington's scores in the ED continue to remain much higher than the national average and follows pretty closely to the national trend. And then this final trend line is a roll-up for all the outpatient and ambulatory areas. Now, and nationally, I think I've mentioned this before, this space is really competitive and they score really high with averages in the mid-90s. And this trend line shows similar declines after COVID, and then again, an upward trend beginning in September 2021. So to kind of wrap up this section, you can see that we experience similar trends as other healthcare organizations, and we also set really high targets. And we work incredibly hard to improve in all of these areas. And like I mentioned before, the scores are the voice of our parents, of our patients. And if we listen to them, and they're going to tell us what's most important and how we're doing. So in addition to monitoring the scores, we also like to pay attention to our patient comments, and we take their feedback really seriously. We read every single comment, and here are just some examples from just last week. And it's common for patients to extend appreciation and remember the names of their caregivers who make a connection and lasting impression. You can see that on here. There were some perceptions that our nurses are really busy. A patient stressed the importance of bedside shift report. There were some challenges shared about controlling the room temperature, etc. And the information and feedback that we gather from Press Ganey surveys is really valuable, but it's also limited. And all healthcare organizations are experiencing survey fatigue. And I'm excited to share, this is really exciting. I'm a little geeked out about it, to be completely honest, but we now have a way to gather even more valuable information and insights from an important practice called rounding. And I know a lot of you know what rounding is, but what is it in rounding healthcare? I think the simplest definition is it's the practice of healthcare professionals visiting patients. And rounding, it's not limited to patients in the hospital, and it can be done in any setting. And so why do we round? We round because it provides us with the opportunity to proactively anticipate and address our patients' needs, and to engage with patients and families, and again, listen and learn about their experience. Rounding is evidence-based, and it's the #1 most effective way to improve the patient experience. And there have been many studies conducted on the effectiveness of rounding, and they all indicate that rounding is an effective means to increase patient satisfaction, quality of care, and it decreases patient safety events. And there is also evidence to support that daily leader rounding improves to the patient experience as well. So there's a lot of different kinds of rounding, and our initial focus is going to be on becoming experts in a rounding practice called nurse leaders rounding on patients. In addition to receiving our Press Ganey information, this will give us the ability to gather way more information from our patients and allows us not to rely solely on patients completing their surveys for feedback. And to do this effectively and efficiently, we have partnered with an organization called Qualtrics. And Qualtrics is a leader in experience management, and they specialize in what I like to call experience software. And the technology allows organizations, and you can see they work with over 700 hospital and health systems, to gather and analyze relevant real-time customer insights. And this helps their businesses learn how to improve their customer experience. The platform is cloud-based, and it has the ability to create surveys, distribute surveys, collect responses, and then even analyze the data. And so this slide illustrates how information is gathered by rounding. And by the way, a rounding conversation is not meant to be a survey. We do not want it to feel like a survey, but it's rather a discussion about their experience and the needs that happens at the bedside. And so the nurse leaders, they access their survey with the QR code and they save it as a favorite. And then they, with their cell phone, they document the answers and ask the patient and family members questions real time. And right now we only have 4 questions, and it focuses on what our patients are telling us is most important, such as communication and teamwork. And we also ask my favorite personal question, which is about how they would like to who they would like to recognize and why. And this is really cool. But if a leader uncovers an issue during their conversation, it can be addressed immediately. Or if, let's say, they realize that the bathroom needs to be cleaned, then an alert can be sent real time automatically to environmental services. And if a patient, let's say they express a concern about being discharged or they're not ready to leave the hospital, an alert can be sent to case management. And so all of this information is captured during the conversation. It's populated in a dashboard real time, and it's very similar to the way we receive the information from Press Ganey. So we actually can gather way more information from rounding in a couple hours compared to one whole entire month of the information we get from Press Ganey. And the good news is that nurse leader rounding on patients and listening to their feedback is happening in other areas in addition to the hospital right now. We're also using the Qualtrics tool for rounding on patients. We're also using the Qualtrics tool for rounding on patients after surgery. And we just started doing this a couple of months ago and have already observed improvement in the scores, and even are right now for the last 2 months in the top quartile. In addition to documenting rounding, we're also leveraging Qualtrics to gather insights in other areas. So, for example, we're going to be piloting a survey in the birthing center to learn more about our diverse community and their cultural needs. And also, we're going to be revising the community or the complaint and comment card so we can gather more information. And in addition to Qualtrics being really helpful for gathering information, it's also helping us with efficiency. So Qualtrics, when we initially were looking into it, it was really designed to support rounding, but we recognized during the vendor demonstrations that it offered additional functionality that we could leverage. And I'm excited to share with you some other ways we're already starting to use the technology, not for just feedback, but also for efficiency. So our first and most challenging project outside of rounding was to automate hand hygiene audits. And hand hygiene is obviously really important for the safety of our patients. And with Qualtrics, we were able to automate a manual auditing process. And this slide just shows a couple of the questions on the audit form that are now on a tablet or a cell phone. And the information gathered automatically populates a dashboard with the results that can then be separated by unit or department. And like I said, we've started using this technology a lot. And the first time was when we did the Nancy Farber Patient First Ethic Award nomination process. It was just a simple shift from a manual process, but it saved a lot of time. And we've also transitioned from a manual to an automated process for surgery safety audits and rehabilitation chart audits. And the hand hygiene alone is expected to save 24 hours a week or 96 hours a month of manual work. And the less manual work, how I look at it, less manual work is more time to interact with our patients and families. So what are our next steps? We are going to expand leader rounding to patients in other areas, including outpatient and in clinics. And next, we will be focusing on tracking leader rounding on employees. And then one final update before I close. Our strategy and work in this space has attracted the attention of Qualtrics and Walker. And we have been asked to be featured in a customer experience leader podcast series where other organizations and experience management professionals are going to have the opportunity to hear our story. And I also want to recognize Athena Kotakalura for her work on this project. We build the surveys and dashboards ourselves, so there's no financial limitations. It's not simple, and I am absolutely amazed at how quickly she has taken ownership and become a subject matter expert. So I started the presentation with how Washington strives to listen and learn from our patients and families. And I hope you have a better idea of the many ways we're listening to our patients so we can respond with the right actions and continue to improve. And I decided I still wanted to end with a quote, and this one is by Sura Hart, and it is, "Listening is an attitude of the heart, a genuine desire to be with another, which both attracts and heals." So what questions do you have for me?
I personally find that really great stuff, particularly the rounding. I think that's amazing. Periodically, I or my wife have contact. You get the survey, and honestly, it's hard to get to it. It's hard to do it. And it's easy to rationalize and say, well, they don't need me. And the rounding seems to fill that hole. I like that. I like that a lot. And it's a personal interaction, which is all the more valuable. That they get someone personally asking them, how was it? That's great stuff.
I mean, we still want our patients and families to fill out the surveys because that's important to do that. But really, like Laura said, to be able to hear from our patients and family and respond at that moment really is important. So that to us is very much important.
Yeah.
Laura, when the nurse managers or nursing leaders do the rounding, are they by themselves or do they have the bedside nurse with them? And is it a one-time event per admission or is it a daily check-in to see how things are going?
Yeah, I think we're going to find that out the more we're doing it, how often, because some units have more beds than others. And so it kind of depends, but we at least want to make sure that they're rounded at least once during their stay. Daily would be fantastic and best. And we're also going to be training the charge nurses to be doing this as well. And then to Kimberly's point, one thing I wanted to mention is that one of the ways that we can increase our end size in one of the number one ways is by asking our patients to fill out the survey. That when they sit down and have that conversation, that they let them know that you might receive a survey, and it's really important that you fill that out because that's how we get information from you. And as a result of you filling that survey out, we have done such and such. We now offer coffee on the unit or whatever we've done, because what patients want to hear is that if they fill out the survey, one, we read it and we do something. So that's one of the main ways that we're going to hopefully increase end sizes is by asking them to complete the survey, that's really important to us. And that's one of the things Preskani has said increases the end sizes the most is by asking them to increase and to fill it out and why, because we do something with it.
Laura, there's one thing that I've incorporated into my rounding with patients, and I try to do it. I'm certainly by no means 100%, but it's to ask at the end of every encounter with the patient or the family, to ask, is there anything that you need now, or is there anything that I can get for you now? And you get different answers. Sometimes they're just patient comfort, sometimes it's food, sometimes it's communications, sometimes it's calling the nurse. So a lot of different things, but it's an open-ended question which is patient-focused and allows them to say, what is their immediate need and how can I help?
Yeah, one thing when I've been doing some of the coaching and the training is you often hear, do you have any questions? And we've turned that around to, what questions do you have for me? Closed-ended versus open-ended. Please tell me what I can do, because there's a big difference. I know it's subtle, but it does welcome those things. So I'm glad you're doing that, because you're absolutely right. And oftentimes they're afraid to say they don't want to be a bother.
Yeah.
Mm-hmm. Yeah.
But when you offer to help, that, I think, creates a better atmosphere, and it also tells them that you're listening.
100%.
Yeah.
Yeah, thank you for doing that, and keep doing it.
I'll do it.
Yeah. Let me clone you.
Yeah.
Thank you, Laura.
Yeah.
Thank you, Laura.
Thank you, Laura.
Laura, I think in all this, especially when you're talking to a patient, I think there should be a balance. Too much of this also may not be very much appreciated by the patient. And a lot of studies to show that, a high score in patient experience and a good discharge planning, there's a direct correlation with less 30-day readmissions. So, just beyond, because we are looking at all these 30-day readmissions, I think, this all matters. So it's just not a direct patient experience. And that's one of the reasons why I think there's a national mood to, not to say patient, but client experience. So I think pretty soon that'll be a new name, client experience and not patient experience.
Yes. Thank you very much, and I apologize for my raspy voice.
Take care.
Thank you.
Thank you, Laura. Yep.
All right. Move on to reports. Medical staff report. Mark Saleh.
Dr. Soleil, are you there?
Yes, sorry, just unmuting. I apologize. Can everybody hear me and see me okay?
Yes.
Yeah.
Good.
Hi, good evening. Dr. Nicholson, I wanted to let you know I had a similar experience, or have a similar experience. When I round, I like to ask the same question, and the answers do run the gamut from everything from, oh, I just need a cup of coffee, or can you help me to the bathroom, to, oh, I need more pain medication, or what is the plan, long-term plan for my cancer? I mean, the whole extent of it. But I do think that people appreciate that very much, that you are interested and willing to help them. All right, for the report, we have a total of 629 providers on the roster, or the medical staff roster. About half, or 343, are active physicians, and 41 are the advanced practice providers. The rest are among the other categories, such as ambulatory, consulting, or administrative. The medical staff is working on several issues that are ongoing, and that includes setting up the emergency department as a separate department. That's basically mostly done, except for some fine-tuning and assigning committee assignments and department chairs and things like that. The other one is the Trauma PIPS Committee. That's the Performance Improvement and Patient Safety Committee that Dr. Chet Morrison is working hard on, along with the medical staff, involving some changes to our manuals to meet the guidelines for the trauma certification. And then finally, of course, is all the ongoing collaboration between the medical staff and administration on multiple fronts such as trauma, aquablation, and the Beta Heart program. And that is my report, unless somebody has any questions.
No. Thanks, Mark.
Thank you.
Thank you very much.
Have a good day.
You too.
We move on to the Service League report. Sheila Vijay.
Good evening, everyone. Good evening to all of you. I'm back in the US now, a little jet lagged, so if I sound raspy, no, I'm just kidding. Yeah, I am out there right now. Anyway, warm greetings from all the volunteers. For the month of March, 193 Service League volunteers contributed 1,705 hours to the hospital. We held a high school information session on March 15th, attended by 42 high school students. The Service League office hosted an open house from 1 to 4 p.m. on Tuesday, April 9th, which was yesterday, which was well attended by both volunteers and employees. Everyone enjoyed snacks and received giveaways, making it an enjoyable occasion. I do really want to extend a very special thank you to Kimberly for making time and joining us for the event. So thank you, Kimberly. We are happy to announce another round of our 3-day masquerade sale happening on April 29, 30, and May 1st. And we look forward to seeing you all there and spending some money on us. Today, bring to your attention a very special volunteer. Her name is Suzanne Corbett. She is 89 years old. She doesn't venture out much. However, she has managed to become a remote volunteer who knits beautiful hats for our newborn babies. I recently had a chance to talk to Jeanette, her daughter, who has been my liaison with Suzanne. She says, "My mother has always been a dedicated knitter, crafting numerous afghans, sweaters, and scarves for our family. Years ago, she connected with fellow knitters at the Fremont Senior Center, where she learned to knit baby hats. During the pandemic, she began knitting hats to stay occupied. Although she faced challenges in sourcing yarn, she persisted in producing about 80 hats by the summer of 2020. Not sure where to donate, she initially gave them to San Leandro Hospital. Eventually, Susan's daughter, Jeanette, contacted a volunteer at Washington Hospital, initiating a steady flow of donations. She continues to knit even today, estimating over 700 donated hats to date. She finds joy in knowing her hats bring warmth to babies, though she regrets not being able to see them wearing her creations. Susan Corbett's story beautifully illustrates how one person can have a profound impact even without being physically present. Her dedication, despite challenges, exemplifies the power of volunteering, reminding us that everyone can contribute meaningfully. She showcases how small acts of kindness inspire community involvement and generosity. We would like to extend our heartfelt gratitude to Suzanne. Her efforts not only provide essential protection to the tiniest heads, but also offer treasured keepsakes for the parents and loved ones alike. Her commitment exemplifies the true spirit of community and compassion. And that's the end of my report today. Please let me know if you have any questions.
Yeah, I have a question, Sheila. How do you do it? When I look at Jeannie handed out the $5 jewelry sale, it's not inflation-adjusted $5. It's not the $6 jewelry sale. It's still the $5 jewelry sale. I mean, you are the strongest inflation fighter that I've seen. I don't know how you guys do it, but I'm thinking we should send you and your team to Sacramento and to Washington D.C.
What can I say, Dr.
And maybe to the Federal Reserve Board.
The most charming lot you have on board. It's the most charming group you have on board.
Well, thank you.
All right.
Thank you very much.
Thanks, Vijay. So we'll move on to the quality report.
Next, it's my pleasure to introduce somebody that we all very well know, Dr. Diane Martin. She is here this evening to give the annual antimicrobial stewardship report. I'll just give a little bit of the background on Dr. Diane Martin. She has been a practicing physician in our community from 1984 until 2023, when she retired from her role as a clinician in the Washington Township Medical Foundation. Dr. Martin has served in many leadership roles at Washington, including chair of the Department of Medicine and chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection prevention. Since her retirement, she has continued her role as the Washington Infectious Disease Program Consultant. She is currently the co-chair with Lena Wong for the Antimicrobial Stewardship Committee and co-chair with Gulnaz Hanif for the Infection Prevention Committee. Dr. Martin also served as one of our key leaders during the peak of COVID response planning, a role she continues today. Dr. Martin attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine. Welcome, Dr. Martin.
Thank you very much. It's quite a privilege to go over one of my favorite topics, which is antimicrobial stewardship. We have a tremendous program here, and I'd like to thank Lena Wong for all the dedication she's put forward through this, as well as many other team members, physicians, and lab staff, and microbiology especially. So next slide outlines our program goals, and I'm hoping the presentation will support how we are working to achieve our goals. So we want to promote the appropriate use of antimicrobial agents and slow down development of resistance. We also want to prevent the spread of infections caused by resistant organisms, and we do that a lot in collaboration with the infection prevention team. We also hope to reduce adverse effects of antibiotics and decrease costs and length of stay. Next slide. So why do we need antimicrobial stewardship? For one reason, there are fewer antimicrobials being developed because of the high cost of research, and there's less return on investment. Compare short-term antibiotic use versus long-term medication use, such as for diabetes, hypertension, hypercholesterol. You can see there's quite an inequality in return on the dollar. Some antibiotics are used long-term, but most of them are very short-term. So we want to make sure that we're conserving and using them to the best of their advantage. So the Antimicrobial Stewardship Program promotes responsible use of antimicrobial agents, and to the best of our ability to optimize existing agents, because these are very valuable resources. Antimicrobial Stewardship Program promotes optimal selection, dosing, duration of antimicrobial agents, provide best outcome with minimal effects and side effects, and reduce subsequent resistance. We work in tandem with other disciplines. This is our team in general: medical staff, infection prevention, medication safety, microbiology, pharmacy, my favorite and support team, IT, and also quality. Next slide. So antimicrobial stewardship works with antimicrobials, which are a critical part of modern medicine. For certain patients that are on chemotherapy, transplant patients, these are at high risk for infections, and the antimicrobial agents treat those infections and protect those patients and help them continue on their other courses of treatment. Antimicrobials are also used for sepsis, which is an overwhelming infection that can rapidly lead to organ failure and death. So without antimicrobials, we don't have any defense against these bacteria. Sometimes with surgery without antimicrobials, many surgeries will not be possible. So there's preventative as well as treatment options with antimicrobials. Also, there are a few episodes where we use chronic conditions such as HIV, hepatitis, where those are needed for long-term chronic conditions. Next slide. So getting a little bit to the more serious side, antimicrobials can save lives, but can also trigger resistance in the replicating bacteria. The bacteria are also fighting for their lives in addition to causing problems, and they are providing resistance against the antimicrobials, and they're developing these at a fairly rapid rate. So antimicrobial resistance occurs when the bacteria mechanisms to defeat the antimicrobials designed to eradicate them. This is a global challenge that we're currently experiencing. Resistance is spreading quickly across the globe. For example, the COVID-19 drugs that we had early on are no longer effective. The resistant organisms render the antibiotics ineffective and therefore negate the benefits of modern medicine. Next slide. So this is our team. So we have medical staff, we have ID physicians, nursing, pharmacy, lab, IT, compliance, infection prevention, and pharmacist leader Lena Wong. We form a committee meets almost twice a month, but also offline with various issues that come up and how to best address these. So without this team, this project would be very, very slow. But right now we're moving at a very fast rate to do a lot of great stuff for this hospital and our patients. Next slide. So these are projects that these are our accomplishments, and I want to address them in detail in the next few slides. And what we're trying to do is to update physicians to provide best care for all of our patients. So we have updated treatment guidelines, such as for gram-negative bacteria, also for viral infections, to optimize the antimicrobials. We do a systematic utilization review. In other words, we look at how often we're using antibiotics, are they used for the best options and purposes, and we're looking at resistance trend because we know this is always going to occur. We want to stay on top of it and work to the best that we can to reduce it or slow it down as much as possible. We're doing continuous quality improvements. We want to identify areas that need improvement, and we implement a process to achieve desired outcomes. Next slide. So one of our accomplishments are basically putting into practice best ways to use the antimicrobials. And we're doing this with the Infectious Disease Society guidelines, as well as CDC and SHN, which is National Health Safety Network, which is Medicare, to design these outlines that help us implement best practices to optimize our antimicrobial use and thereby slow down resistance. Resistance is inevitable, but the more judiciously, the more safely, the most rational use of our antibiotics prolongs basically the lifespan of these life-saving treatments. We develop treatment guidelines, some of which are disease-specific, so we're treating pneumonia, skin infections, urinary tract infections, blood infections. Some are pathogen or bacteria or viral specific. Carbapenemase is an enzyme that's produced by many organisms, which induces resistance. So we're looking at that specifically. We look at C. difficile, which is a related result of antibiotics, where you have bacteria in your system which are naturally there. And when you're basically taking antibiotics to kill off the bacteria causing your pneumonia, the C. diff, which is Clostridia, is still in the colon and does not get taken out by the antibiotics, and then causes diarrhea and sometimes very serious illnesses. Also, we look at COVID-19. We're still seeing COVID-19, so we are still developing practice-specific recommendations for treating this. We look at drug-specific. We look at vancomycin, daptomycin, or antifungal. These are very valuable, getting some resistance trends, which we're monitoring very carefully to make sure we use the right drug, right dose for the right reason. We've developed order sets, such as the COVID-19 order panel, and also in the emergency room, ED, we're developing skin infection order panel that helps the ED docs who move very fast look at patients, assess appropriately what's going on, what's the best route of treatments for these patients. Do they need to be admitted? Can they be sent home with antibiotics? Do they need to come back? It helps in all of those parameters. We also have ID physicians that are on consultation available for specific antimicrobials. For some of them that are ultra high resistance, we want to make sure that they are used appropriately. So we our physician team members to consult one of the ID docs when these are used, so that in collaboration, we can provide best care for our patients, maintain these antibiotics for as long as possible. Okay. So another accomplishment has been to review how we currently use antibiotics and how we can reduce resistance. So the CDC has the NSHN, which is National Health Safety Network reporting, which is required by CMS and Medicare, but also helps us see what's going on within our organization and sometimes helps us benchmark against other facilities. We review the antimicrobial utilization and resistance trends on a regular basis. And based on this data analysis, the stewardship team will identify areas of improvement and engage pertinent care team members, whether it's pharmacy, infection control, or some of the ID docs to help us streamline what we think would be most effective use of our antibiotics. Another tool that's provided by the lab is an antibiogram, which is local susceptibility testing trends for our bacteria. So it's done yearly and it looks across a broad range of bacteria and helps us track year to year where we're seeing more and more resistance. This is then provided to nursing staff, to the physicians, and helps us decide sometimes when we're anticipating a certain bacteria staff, what do we want to use for this? What's our resistance panel? Can I use one antibiotic? Am I going to use another one less frequently because it's had more resistance? This helps us in a tremendous way. We also do ongoing monitoring of resistant bacteria, which I pointed out before is the carbapenemase bacteria, so where we have very limited treatment options. So there are antibiotics that are very effective against these bacteria, but again, we want to make sure that we include guidelines to make sure these are used best possible way. Next slide. This is a benchmarking antimicrobial usage trend. So I know it looks really busy, but you're looking at almost 4 years worth of data here. So what we do is benchmark ourselves against other institutions. Some that are like size, some are bigger, some are like Stanford, UCSF, that see way more resistance. But what we try to do is benchmark ourselves. So one is the line that's going right through the middle. That's the average. If we're below the one, we're better than the average. If we're above the one, then we're worse than the average. So you can see in the COVID, we kind of dipped down quite a bit, got down to 0.9. And then you can see the trend starting to go back up. And a lot of this is census. We're seeing more and more patients. And unfortunately, they tend to be a lot more seriously ill. But if you look at the very last one, March of 24, we implemented a number of educational pieces, both for the physicians and for the nurses. So I think it's beginning to show a benefit here. So we'll continue to monitor these trends over the long run. Next slide. So another way that we work on our goals is through quality improvement. So we do this particular process called plan, do, check, and act. So with planning, what we're looking at is another way to assess the situation. We're looking at our medication use analysis. We identify areas of improvement. Then we move on to sort of how we're going to put these guidelines. If we develop them, how do we put them into effect? We look at order sets, we look at protocols, we look at the workflow and EPIC, ways to optimize the antimicrobial usage, whether it's setting a soft stop limit at day 3, you stop your test results or culture results. Am I using the appropriate antibiotic? Should I be using something else? Should I be using less dosage? So all of these are built into our process. Then we want to check. We want to look at our compliance. We want to look at our challenges. Where do we need to make improvements? And then we do an act. We make changes, we adapt, and we improve with the workflows, the guidelines, the order sets, and our protocols. Next slide. So this is also listing, I'll brag a little bit about our accomplishments. So with working with the emergency room, we developed best practices again for antibiotics for skin and soft tissue infections, because they're looking at a lot of people going on and some need to be admitted, some are a candidate for going home with antibiotics, helping them decide how to best treat these patients. We also developed with the laboratory screening criteria where we send our cultures to a reference lab. And what we're looking for is a resistant gene. So those would tell us specifically not to be using certain antibiotics, only use other ones that are basically going to compensate for that resistant gene. Another thing that we've started is to implement an ordering process for what we call novel, which is basically our newer antibiotics. And it includes what we call a timeout. So basically, we encourage the physicians to sort of sit back and say, am I doing the right drug for the right reason, for the right duration, for the right dosing? And that certainly helps sort of sit back, assess where you are, and do we need to make changes? We also modified the C. diff testing algorithm, and this helped us prevent unnecessary treatment because we were looking at a one-prong treatment result, which wasn't as specific as what we really needed. Then with the labs assistants, Dr. Levin in particular, and Raj in the micro lab helped us put together a three-pronged approach of the testing, which gives us very specific information and can tell us specifically what we need to do for these patients. So that's helped a lot. Shorter course, hopefully improved outcomes. We're looking at that. We've also educated our staff on the laboratory testing that can help determine when to discontinue antibiotics. So if we're looking at a PCR, which would tell us if we're dealing with influenza or RSV, which is a viral infection, versus possibly a staph pneumonia, then we can sort of tailor the antibiotics and give the patient the right dose for the right reason. So some of the tests that we're doing is a procalcitonin, which helps us determine a bacterial versus viral, and then also MRSA, which is methicillin-resistant Staph aureus, as opposed to methicillin-sensitive. So methicillin is a penicillin-like antibiotic, which helps us determine if we're dealing with a very aggressive staph. And the PCR is basically a swab test that gives us a turnaround time in a few hours that helps us know right then and there what's the best treatment for our patient. Also prevent spread, because if a patient has MRSA, they're put in isolation so we don't contaminate environment, staff, and other patients. Next slide. So we work in collaboration with a number of care teams. One of our care teams is microbiology. As I mentioned before, we have the annual antibiogram, which helps us track susceptibilities and resistance. We also have the option for customized antibiotic recommendations based on our susceptibility patterns. So we can provide the correct dosing for our patients, knowing what our most common resistance patterns are. We also look at antimicrobial susceptibility reporting in EPIC, and this is to help us use the most narrow spectrum rather than a broad spectrum, which might not be needed, help us tailor the antibiotics for the particular patient. We also do susceptibility testing, and again, these are the breakpoints, which would say this bacteria is resistant against that particular antibiotic. We need to use a different antibiotic. So it helps us tailor the treatment for the individual patients based on their culture results. We also get new drug information which comes available and helps us tailor again our treatment. As mentioned before, we do the viral genotypic testing, which helps us assess whether we can do antimicrobial de-escalation. And the other ones I mentioned before is PCR panel, where we can do a swab of a patient coming in with fever, cough, congestion, terrible looking chest x-ray. Is this a virus that we're dealing with, or is this a bacteria that we're dealing with? And the PCR definitely helps with that. Next slide. Another area of collaboration is with infection prevention, my favorite team. We, in process, looked at ways that we can facilitate a decrease in MRSA infections. We also looked to see if there are ways that we can make a more accurate diagnosis and also decrease unnecessary antimicrobial prescribing. So if we don't need the high specific antibiotics, we can use the more routine ones, then we're better off in terms of preserving those antibiotics for when we really, really need them. They also monitor trends of resistant organisms, and these are shared across our community to all of our hospital departments so that everybody stays up to date on monitoring the resistant trends. Next slide. The other collaboration is with microbiology and infection prevention. So together we look at blood culture contamination. So sometimes blood cultures are not collected properly and can be contaminated with basically staph germs, which are skin bacteria. So we look to analyze that and reduce that as much as possible. We also look to make sure, as I mentioned earlier, that we're using appropriate sample collection when testing for C. diff, so we can make sure that we're doing the right diagnosis and the right treatment for those patients. We also do screening criteria, as I mentioned earlier, to send for resistant bacteria for gene testing. And the goal is to try to improve detection of these resistant organisms, make sure that they stay in isolation, and optimize the initial antibiotic selection, which would help in the long run. If you're not changing back and forth, if you can start out with the right drug and the right dosing, then the patient's going to get better, faster, and we have less complications. Next slide. We also work in collaboration with pharmacy. One of the areas we have worked on is changing from IV to oral antibiotics, which helps facilitate discharge and also decreases the number of days that they have IV lines in place. IV lines themselves are a risk for infection. So if we can safely translate from IV to oral antibiotics, then patients are going to be easier to help facilitate discharge and also reduce secondary infections. Not all antibiotics have this option. There's just a very few, but we want to target those and make sure we have that available. Antibiotics are also dose adjusted with the pharmacist based on kidney function, such as renal dialysis, severity of illness, an ICU patient versus a patient who's on the regular medical floor, and also body size influences the dosing of the antibiotic. With the pharmacy, we collaborate with the medical staff for best practices for empiric broad-spectrum antimicrobials and to include our implementation of approved treatment guidelines. So we want to use the right drug for the right reason. Next slide. So in wrapping up, we want to make sure that we're engaging across the spectrum. We want to provide regular reports to the physicians and the staff on our utilization and resistance trends. We want to share process improvement analysis and opportunity to optimize antibiotics usage with the medical staff. We do ongoing education for physicians and staff on new and updated patient care guidelines. We also have online education modules for nurses and pharmacists. So that kind of concludes my presentation, and I'll take questions.
Diane, it looks like on the whole, we're still a little above one on the antibiotic usage trend. Where do you think that lies? Is it patients who are receiving antibiotics for whom they truly don't need them? Or is it just the length of treatment for patients for whom antibiotics are truly indicated?
That's a really good question. It's obviously an area that we're working on very strongly and trying to improve. So not only specific antibiotic usage, but also the length of an antibiotic, because many of the societies have suggested that cut down by 2 to 3 days without harming the patient. I mean, patient first ethic, we don't want to cause a more serious illness. We want to make sure we're using the right dose, the right duration. So really good question. It's very hard because some people go, if some is good, more is better, or I'm not comfortable stopping it. But the national guidelines have supported a lot of these earlier discontinuations in total of antibiotics, but also changing from IV to oral antibiotics so the patients can go home and they're in a more comfortable environment. They can pick up their daily routine and they're less exposed to other things. So super good question. We are really, really working on that. A lot of it is due to census because we just got kind of maxed out and hard to control this. But I think we're really, really working with it. And we have a super good physician team and rolling out this information. Presentations to almost all family medicine, surgery, and also medical staff. So super good question. Yes, we were on the top of our list for our projects for this year.
Okay, I wish you best of luck in working on that. I have seen progress on both ends,
Yes.
Increased use of procals and stopping antibiotics early.
Right.
And reducing the duration of antibiotics when they
Right.
have been indicated. So it's good progress overall. It's nice to see that.
There's some of those PCR tests which help us determine if we have an MRSA versus sensitive staph right up front. So we're working with the lab to try to figure out, we have a lot of information that we can use. We just need to kind of get it going and out there to the physician teams.
Yeah, the education of the healthcare team is
Yes.
I think, going to be a
I usually
key-
tell people my
key
best
driver.
treatment is education.
Yeah. Thank you, Diane.
So I appreciate the ability to send a message out to the community. So we're really working strong and hope give you next year an even better report.
Diane, talking about the drug resistance, especially in tuberculosis, which is a big thing now,
Yes.
multiple drug MDR.
Yeah.
And the WHO projection is about 18% of mortality in the world would be from tuberculosis MDRs.
I almost put that in here because that's a huge topic. And you're right. We are seeing in Alameda County alone, we're seeing a huge surge in the two hotspots, Oakland, Fremont. And a lot of what we're seeing is what you pointed out is the latent tuberculosis. There are many patients who have been infected and carry the tuberculosis, have not been tested. The county is looking at this very intensely right now, and they gave me some of their slides, which I use for some of our presentations, but you are spot on the TB. I almost put this in here, but I figured I didn't have time to talk about everything, but you are spot on. You are spot on.
Especially with the high incidence in Eastern Europe and Sub-Asia.
Yes.
And Far East.
Yes.
And, we got so much of, immigration, from all those countries. So,
I think you're right. And we also see a lot of visitors. And I think, we see people that travel back and forth a lot. So I think, that is a huge area that we need to talk to patients about is travel.
Mm-hmm.
So thank you. Thanks for bringing that up. I wanted to, but I was not going to do it. But thank you for letting me put in my extra 2 cents.
Well, it's probably something we should have as another education session. It sounds.
Well, I've been including it with the presentations to the departments, and I'll bring it to the next medical staff department. But my other wish list is a newsletter. So I figure I could probably reach a lot of people that way, even if they spent 2 minutes looking at it. So an electronic would save paper.
Mm-hmm.
Well, if you're vaccinated as a child, like I was, do I have to get revaccinated or what?
I'm sorry, I missed what you were saying about
Well,
revaccinated.
almost everybody was vaccinated for TB as a child.
Right.
And
So
do we need to get another shot or?
we don't have so much. You're saying TB shots? Is that what you said? Yeah,
Yes.
we don't have that so much, but we do want to do treatments, which is basically just a blood test. They have a what's called a quantiferon, which can check to see if you have active TB, and then your physician, your primary care provider, would then treat you for that. And there's some courses that are very short. I mean, as short as 3 months. It's not the year stuff. I mean, because I converted to TB when I was in medical school, and basically I was on that stuff for a year. But now we have very effective, very short courses.
Yeah,
So good question.
the tuberculosis vaccine, BCG, actually is not given in this country, but
No.
and it's just once. There's no booster doses. It's just once when you're born. That's pretty much it.
Right.
But then there's a lot of questions or question mark about the effectiveness of BCG anyway. So
Yes.
yeah.
Most immigrants have had it.
Sorry?
Most immigrants have had it.
Yes, yeah, we've all had it, yes. And that's one of the reasons why, they don't recommend PPD testing for, a population that have received BCG because there could be false positive. And that's where the quantiferon.
Quantiferon works very well. I mean, it's such a fast turnaround. And in long term, costs less because the PPD, you have to come back and get it checked. Thank you for bringing that up.
Thank you.
Thank you, Diane.
I'm going to sign out, but thank you guys. Appreciate it.
Finance report?
So we have our financials. Our CFO and Vice President Tom McDonough is joining us. He's a little under the weather, so he's joining us from online. Tom, are you there?
I'm here.
Okay, Bill.
As I take my throat lozenge and take a sip of water, I think there's a handful of us tonight that we're very happy to hear Dr. Martin's presentation.
Yeah.
So I'm happy to share the hospital's final financial data for the month of February 2024. On inpatient average daily census was 166.4, higher than the budget of 165.7, though we continue to trail on a fiscal year-to-date basis by 5.3. Our combined average daily census of 176.5 was higher than the budget of 174.8, yet continues to trail just slightly on a fiscal year-to-date basis by 3. Discharges were favorable to budget by 28 for February, and on a year-to-date basis, we do trail by around 5%, 6%, excuse me. Patient days were favorable to budget by 21 for the month of February. Outpatient observation equivalent days at 293 were unfavorable to the month's budget by 29 days and are unfavorable on a fiscal year-to-date basis by 576 days. The average length of stay, or ALOS, at 5.53 was unfavorable to our budget by 22 basis points, or 4.1%, while the fiscal year-to-date average length of stay at 5.38 trails our budget of 5.24 by just 14 basis points. For operating indicators, our case mix index was favorable to the budget for February at 1.673 compared to a budget of of 1.589. And 1.579 actual on a fiscal year-to-date basis exceeds our budgeted number of 1.551 by almost 3 basis points. Deliveries in February came in at 123, above budget by 14 or 12.8%. And we trail ever so slightly on a year-to-date basis by 3 or 0.29%. Total surgical cases in February totaled 484, favorable to a budget of 455 by 29. Cath lab cases for February came in at 191, below budget by 9% or 19 cases. Non-emergency outpatient visits of about 8,400 were above the budget by 276 and are above the budget on a fiscal year-to-date basis by 475. Emergency room visits for the month of February totaled 4,950, above budget by 200, and are below fiscal year-to-date budget by 767, or 1.9%. This is the breakdown of the surgical and cath lab cases. As mentioned, we exceeded budget by 29 cases. And you can see that while we trailed budget in the orthopedic and the neurosurgical cases, we exceeded in the cardiac, the vascular, the endoscopy, and the ever popular other surgical cases by 25. In the cath lab, we were below budget by 19 or 9%. Contributing to the shortfall was variance in budgeted cases in peripheral, non-vascular, and neurointerventional radiology. Though we did have a fairly strong February in cardiac, and that appears to be due to Dr. Agarwal coming in and performing some cases there. For operating indicators, blended FTE, favorable to budget by 3.6 for the month of February and favorable by 24.7 on a fiscal year-to-date basis. February's blended net non-productive FTEs were unfavorable, however, by 13.4 for for the month and continue to exceed our fiscal year-to-date budgeted number by almost 21. Blending these two numbers together, we show that we are unfavorable for the month of February at 9.8 by 9.8 when compared to the budget. And on a fiscal year-to-date basis, we are favorable by 4. Total FTEs per adjusted occupied bed came in at 5.89, which was favorable to budget by 25 basis points, and is also better on a fiscal year-to-date by 28 basis points. Gross patient revenue came in at $204 million for February, which was favorable to the budget by $11 million, though it did trail. We still trail on a year-to-date basis by $8.7 million. And then for February, our contractual allowance or payer reductions was unfavorable to budget by $9.6 million. You'll see that in the second line, about 6.7%. Provision for bad debt, which is in the next section, came in at 1.48, so lower than the budget of 1.83. And excuse me, this brings our total deductions to $156.24 million, which is unfavorable to the budget by 9.1. Contractual reductions as a percent of revenue came in at 76.57, or 34 basis points higher than what was budgeted. So here we show the income statement on a GASB basis. Gross patient revenues, again, with $204 million. The contractuals as a percentage of revenue were 76.57 on a budget of 76.23. You can see our net operating income for the month of February was positive by $248,000, though it did trail the budgeted NOI of $402,000 by $154,000. And then if you look on a year-to-date basis, we do trail our budgeted number by $13.3 million. Operating expenses came in at 48.6 in February, which were 1.6 million unfavorable to the budget, or about 3.5%. Our non-operating income was favorable to budget. This is due mostly to the gain our investment portfolio enjoyed during the month, both realized and unrealized, and a receipt of a FEMA reimbursement grant. So FEMA reimbursed us for some COVID items in the month of February, and we recognize that as non-op income. So total net income was 2.6 million on a budget of 4 million for February, and we trail on a fiscal year-to-date basis by 6.9 million. Excuse me. So now we look at it from a FASB perspective. You'll notice some of the numbers have changed. On the net operating income, FASB shows us as negative 501,000 instead of GASB, which showed us at 248 positive. And the budget would have been a negative 142. And then on the net income side, you can see that FASB has us at 3.6 million on a budget of 3.7, and we trail here by about 9 million from our budget if we were subject to FASB. So GASB EBITDA, we'll draw your attention to the fifth line down from the top. EBITDA exceeded budget. It totaled 3.7 million for the period of February on a budget of 3.4 million. And on a fiscal year-to-date basis, EBITDA is 18.7 million versus the budget of 30.5. So we trail by about $11.9 million. And with that, Mr. Chair, that concludes my report for February.
All right, thank you, Thomas. Now we'll move on to the hospital operation.
Thank you. I will present the March preliminary operations report, March 2024. So starting with the first slide, you can see our patient gross revenue of $213.2 million for March was favorable to the budget of $211.8 million by 0.7%, but lower than March of 2023 by $3.1 million or 1.4%. And as you can see below at the bottom, you can see that March was one of the 3 high revenue months in the past 12 months. Fiscal year 2024 quarter 3 was favorable at $633.4 million compared to the budget of $610 million by 23 or 3.6 million. So if you look at our gross revenue quarterly, you can see that we have been continuing to contribute about $20 million per quarter in 2024 fiscal year and continuing that road to recovery effort. Moving on to the breakdown with our preliminary gross revenue, you can see that inpatient gross revenue of $126 million was unfavorable to budget by $7.8 million or 5.8%, but 1.7% higher than March of 2023. Our outpatient gross revenue of $87.2 million was favorable to budget by $9.2 million or 11.8%, but 5.6% lower than March of 2023. Moving on to the key census statistics, starting at the top with the average length of stay came in at 5.14, which was favorable to budget by 5.23 by 1.7%, and was lower than the March 2023 average length of stay of 5.48. Outpatient observation equivalent days at 287 were favorable to the budget of 299 by 12 equivalent days or 4%, and also less than March of 2023 by 3%. Looking at the inpatient average daily census came in at 169.1, was unfavorable to the budget of 185.2 by 8.7%, but higher than March of 2023, which came in at 165.7. And lastly, looking at the combined average daily census, came in at 178.4, was unfavorable to the budget of 194.8, or 8.4%, and higher, 1.8% higher than the March 2023 average daily census. Moving on to discharges, discharges of 908 were unfavorable to the budget of 1,097 by 17.2%, but also 5% fewer than March of 2023. Looking at patient days of 5,241 were unfavorable to budget of 5,345 by 1.9%, and they were also 2% more than 2023. In terms of the areas we saw, in terms of favorable to budget, our ICU days were favorable to budget along with our telemetry days, and our IMC days along with SCN and adult med surg were under budget. Moving on to the surgical trend, our total surgeries in March at 476 were 1.7% or favorable to the budget of 468. Surgeries were 3.6%, though less than March of 2023. But still strong showing. Inpatient surgeries at 201 were favorable to budget by 2.5%, but 9% fewer than March of 2023. And outpatient surgeries at 275 were favorable to budget by 1.1%, and 0.7% more than March of 2023. If you look at the breakdown in terms of of our surgical activity, just looking first at the orthopedic surgical cases, they were unfavorable to the budget by 20 or 10.2%, and were 17.7% less than March of 2023. I do just want to make sure that everybody's aware. Dr. Saw did do 31 cases at Washington Outpatient Surgery Center, our ambulatory surgery center that was not budgeted. So in terms of over there, so that was on one piece of it. Also, Dr. Dearborn, he did do 52 cases at Peninsula Surgery Center, though he was budgeted for doing 51 cases there. So the delta for the orthopedic surgery is really aligned with Dr. Saw doing still within our healthcare system that at Washington Outpatient Surgery Center. Looking at our neurosurgical cases, they were unfavorable to budget by 9 cases and were 4.3% less than March of 2023. Cardiac surgical cases were unfavorable to budget by 6 and were also 6 less than March of 2023. Vascular cases were unfavorable to budget by 25 and were 27 less than March of 2023. Endoscopy cases were favorable to budget by 57 cases and were 34 more than March of 2023. And lastly, all other surgical cases combined were favorable by 11 and were 20 more than March of 2023. Moving on to our cath lab. Cath lab cases for March came in at 186 that were 27 or 12.7% unfavorable to budget of 213, but were 17.7% more than March of 2023. So we've been continuing to climb in our cath lab volume, but still not exactly where we had budgeted. Our inpatient cases at 92 were unfavorable to budget by 18.6%, and outpatient cases came in at 94 that was unfavorable to budget by 6%. You can see on the next page in terms of the cath lab activity broken down. Cardiac cases came in at 8.4% unfavorable to budget. Again, we've been seeing growth in the cardiac cases through Dr. Agarwal. In non-vascular interventional radiology cases, they came in at 17 cases below budget, 25.8%. Peripheral vascular cases came in at 42, which was unfavorable to budget by 9 cases or 17.6%. And we did have a busy neuro IR month, and they came in at 8 cases, which was favorable to budget by 7 cases and also favorable to March of 2023. Moving on to deliveries. Deliveries for March came in at 134. That was unfavorable to budget by 9 or 6.3%, and also 6.3% fewer than March of 2023. Our C-sections came in at 46 or 34.3% of total deliveries, which was lower than the budgeted 37.8% of total deliveries. And year to date, we have 1,138 deliveries, which was unfavorable to budget by 12 or 1.1%. So we keep getting very close to getting to the budget year to date, but then going to go up and down, as we know. In terms of non-emergency department outpatient trends, they came in at 8,756, which were favorable to budget by 1.7%. This was driven by our imaging services that was 12.4%, favorable to budget cardiac rehab visits at 21.3% favorable to visits, and EKG visits that were favorable to budget by 0.5%, and was offset partially by our lab visits that came under budget by 7.8%. I will say our emergency room visits continue to be, our emergency room department continued to be busy, had 5,162 visits, which was favorable to budget by 50 or 1%, and were 93 or 1.8% more than the prior year. Then moving on to our gross revenue recap. Surgical revenue was favorable to budget by $201,000 or 0.6%. And cases were 8 or 1.7% favorable to budget. Our cath lab revenue was $548,000 or 4.3% unfavorable to budget, and this was driven by higher neuro IR volume, as I mentioned, because as we know, cases were unfavorable to budget by 12.7%. Room and board revenue was favorable to budget by $298,000. Delivery revenue was favorable to budget by $277,000 or 7.1%. And then emergency department revenue was favorable to budget by $94,000 or 0.7%. And lastly, ancillary services revenue was favorable to budget by $1.1 million or 1.1%, driven quite a bit by our infusion services. Moving on to our preliminary payer mix, we did have another challenging month in terms of payer mix. As you can see, government-sponsored patient revenue made up 75.1% of total gross revenue. This was unfavorable to the budget of 74.7%, but lower than the prior year's percentage of 75.9%. HMO gross revenue was 2.4% of total gross revenue, favorable to the budget of 2.3%. This was higher than the prior year's percentage of 1.7% of gross revenue. Our PPO gross revenue was at 20.6% of total gross revenue, unfavorable to the budget of 24.1%, and also lower than the prior year's percentage of 22.1%. And lastly, our private pay gross revenue of 1.9% total gross revenue was unfavorable to the budget of 1.4%. We did have a total of $1.2 million in charges from out-of-the-country patients, and there were 3 accounts that totaled about $638,000. Moving on to our productivity indicators, our productive FTEs were favorable to budget by 126.4 or 8.1% at 1,438, and our non-productive FTEs were unfavorable to budget by 57.3 or 38.1% at 207.9 FTEs. Overall, our total FTEs of 1,645.9 were favorable to budget by 69 or 4%. Also favorable to budget was our total FTEs adjusted per occupied bed that came in at 5.75 compared to a budget of 5.85 and better than the prior year that was at 5.8. Looking at our Washington Township Medical Foundation outpatient statistics, clinic visits were unfavorable to budget by 9.3% for March. In terms of primary care, they came in unfavorable to budget by 10.5%. However, we've been looking at the run rate for March, which was 409 visits per day, which was up from 360 per day in July. So we're continuing to track that. We also had some visits due to open provider at our Civic Center location and our Nakamura. We do have 2 new physicians that will be starting and 2 advanced practitioners that will be starting in the summer, and we have 1 offer that's pending. So we have a number. We're doing a lot of work in terms of trying to recruit into the medical foundation and primary care. And in terms of our specialty visits, they were down 8%, and again, working on open positions in psychiatry and wound care. Looking at Radiation Oncology Center in March, treatments were at 290, which were 161 below the budget of 451. There were a couple of things, as we know, we've talked about this in terms of with our new linear accelerator, with more targeted approach, we do see less treatment visits. We also had 1 holiday in March in terms of that we were not treating. But we're continuing to look at ways that we can increase referrals. We did have 24 new treatment starts which were 4.4 higher than the fiscal year 23 average of 19.6. We had 20 new patients seen in the clinic, which was lower than by 4.8 than fiscal year 2023. So we're continuing to look at how we
Should we
the referral.
switch from a total treatment, per treatment to a new start metric?
Yeah, we're going to be changing some of the metrics. We didn't want to change in the middle of the year. So in July, there are a couple of new metrics. This will be one. There are a couple of others I know Tom McDonough and I have been talking about in terms of just presenting so that we can really better give a picture of what's happening. So
Probably we can have both side by side.
we can have both side by side. So, we can look at in terms of what makes the most sense. I think, as I said, I think that's where we really need to.
Does radiation oncology get paid for a course of treatment or on a per treatment basis?
It's a global fee.
It's a per treatment.
Per treatment.
So,
Okay.
meaning though, it's not for the course of the treatment, it's per treatment. So less fractionations means.
Less revenue.
Yeah.
Correct, less revenue, which opens up capacity on the system, which is where we need to really grow that regional cancer center. Right.
So. Great. Moving on to the outpatient statistics for DevCo. The outpatient visits of 2,205 were unfavorable to budget by 65 or 2.9%, and 6.8% less than March of 2023. The main drivers, we did have a physical therapist that was out, so that the rehab center came in 5.4% below budget. WASC was favorable to the budget by 0.7%, and PSC was also favorable to the budget by 18 cases or 25%. Moving on to our key financial statistics. In terms of our days cash on hand, you can see we ended at 130 days, an increase of 10 days from prior month. Driven by sort of three main areas. The first is we did receive $13 million from rate range and QIP funds. This equated to 8.7 days. If you remember, our QIP is a payment program where it is tied to achievement on quality measures, and we've done quite well with that program, and it's focusing on the Medi-Cal population. The other is the Intergovernmental Transfer Voluntary Rate Range Program, which provides us an opportunity to receive additional federal matching funds in support of health services that we provide to the Medi-Cal population. We also saw a $500,000 increase in investments and unrealized gains, and also decrease in accounts payable that all contributed to this additional days. And lastly, there was $154,000 in charity care adjustments in March of 2024. And lastly, just in terms of the oversight, in terms of unhoused activity for the period of July through March of 2024, the total unreimbursed costs for the period of time, the 9 months, is $4.4 million. And for that time, there were 1,629 patient encounters representing 789 unique unhoused patients. Of the 789 unique unhoused patients, 270 had multiple encounters with the hospital. And continuing to look at ways that we can help to decrease that. One of the ways that may have an impact is our partnership with the Alameda County and the Hume Center in terms of mental health services on an outpatient basis, and being able to do that warm handoff from the emergency room to that outpatient, those outpatient services. So continuing to look at ways to see the types of services that can be provided. And that is my report from March 2024. Any questions? All right, can I move on to the other piece? Yes, I'd like to start with our Employee of the Month for April of 2024, which is Soledad Fernandez. She's our environmental services aide and known to many, many throughout the healthcare system, especially the hospital and the second floor, maternal and child health. But Soledad, in 1990, when Soledad Fernandez accepted an assignment from an employment office, she had no idea it would lead to careers for her and for her children. Her assignment was to work in the Environmental Services Department at Washington Hospital. She found the work rewarding and the people nice, so when Soledad was offered a full-time role, she accepted. For the past several years, Soledad has worked on the second floor of the main hospital in the maternal child health department. She has worked in different areas of the department, including the special care nursery, where she's had to learn to clean quickly and quietly. And she says, the first thing I learned was not to scare or disturb the babies. Soledad feels grateful to be working in the maternal and child health department because, as she notes, there's a lot of happiness on the floor. Her admiration for her colleagues is matched by theirs for her. Soledad is frequently complimented by clinical staff and physicians. Her hard work is enhanced by her positive attitude. When Soledad says Washington Hospital is like a second home to her, it's almost literally true. Since she began her career here, this Fremont resident has raised four children, all of whom work at Washington Hospital. Jose works in the laundry department, Tiffany is a PBX officer, Heidi works in physical therapy, and Emmanuel is a supervisor in security. Soledad's commitment to hard work and our organization has been a benefit to Washington Hospital in many ways, and we're so happy to congratulate Soledad on being our Employee of the Month. It's a great story.
Yeah.
It is. She is. All right, next I'm going to move on to our health promotion and community outreach events, and we'll start with our past ones that started in March. And I want to start March 20th. Lena Wong, diabetes education, presented on Facebook Live and YouTube, Managing Diabetes with Exercise, and had 105 live views and 385 non-live views. You can see that on the 23rd, we hosted an educational booth at Newark Annual Family Day at the park, and we did blood pressure checks there. On March 27th, Dr. Imam talked to Acacia Creek and Masonic Homes and talked about dysphagia and reflux disease. On the 28th, I do want to talk a little bit about this important partnership that we have. And we had an event at Federico's Grill in Niles, and it occurred on National Choking Awareness Day. And many of you are aware of Kiko Rodriguez, who was a co-owner of Federico's Grill in Niles, and he definitely was an amazing community member with a big heart. And unfortunately, he passed away due to a choking event. And so his family, community members, partnering with Washington and many others, have agreed that we want to try to turn something that was a very unfortunate event into something that we can help for this community and do some good, and hope that we can't change the past, but maybe we can change the future for others. And this was the kickoff of doing education for different restaurants throughout the district and for the community at large. And so you will see in some of our upcoming events that we have a number of choking education that we will be doing for the community. So very excited to be partnering with many people on this. And then lastly, you can see April 5th, Dr. Dwan did a Facebook Live will be doing, or did, in terms of sun, beauty, and bees. And here are some of the different pictures from Newark Family Day, dysphagia and reflux disease presentation. This is from Choking Awareness, and Angus got to do a demonstration with Betty Goodwin, our clinical nurse specialist from the emergency room.
It's good he survived.
Yes. Also, I want to just make everybody aware that the Joint Commission was here to do our recertification for our primary stroke program on April 4th and 5th. We are still awaiting the final report, but preliminarily we did very well. I want to very much thank our co-medical directors, Dr. Rose and Dr. Kalsa, and along with our program director, Maria Nunes, for all of the hard work. But really, it was a team effort, and everybody from the 6th floor, from the procedure areas, from the emergency room, through all the ancillaries, everybody, it was strongly collaborated, and we had a very successful survey. I do want to, our surveyor really said that we are very much have made a lot of improvements towards being a comprehensive stroke program, and really applauded all of the education and collaboration that we have throughout the healthcare system. So I want to thank everybody that's been involved, and I know we've been waiting for that survey for a few months. So next, just in terms of our upcoming outreach activities, you can see in terms of what's coming ahead. I do want to point out a few. In terms of April 17th, J.B. Goodyear, Spiritual Care, we'll be talking about grief and grieving at Carlton Senior Living. We are part of participating in the Washington and City of Fremont Go Green with Us in 2024 Earth Day celebration, and that's happening, as I said, on April 20th. Dr. Saw on April 24th will be talking about in the Anderson Auditorium, and also Facebook Live, robotic knee surgery and muscle-sparing anterior hip surgery. And then also just pointing out on April 25th, we are doing a choking first aid training at La Cabana Restaurant in Newark. You can also see we have many other events in April. It is going to be a busy month in terms of that New Haven Day at James Logan High School. Again, other choking first aid training that we will be doing in the district. Dr. Harsh Agarwal will be talking about heart valve disorders at Acacia Creek and Masonic Homes. Also, it is going to be both Nurses Week and Hospital Week, and we will be celebrating it as the Healthcare Systems Week with a variety of events and recognition for everyone during that week. And on May 7th, Dr. Rose, our neurologist, will be talking about stroke prevention awareness. And I do want to just say that I know we had our board members that were represented at the Alameda County Special Districts Association Annual Dinner on March 21st. And then lastly, we do have, important on May 2nd, is our 37th Annual Golf and Bocce Tournament that will be happening at the club at Castlewood in Pleasanton. We're very excited for this event. It's always fun and have a lot of participation. And the funds will go to support the purchase of equipment for the hospital's operating room. So just want to thank all those platinum sponsors, including Fremont Bank and Gonzalez and Kozachenko. And that is my report.
Good. Any announcements?
I do not have any other announcements.
All right. So with there being no further business, the meeting is adjourned. Good night.
All right. Thank you.